So good afternoon, good morning, good evening, depending on where you're joining us from, and welcome to this fourth daily lightning session with Francois Gaz and myself. And I'm going to start by saying happy Feast of the Tabaski to all the Muslim scholars, all the Muslims in the COVID-19 peer hub. We are with you in this day. So we hope you're celebrating well. So we just wanted to start by saying happy feast day, happy celebrations to you all. And as you know, we always say as you're joining, you type in your city and your country, and you make sure that you're typing, that you're writing to all panelists and attendees. So I greet you, Isaac Bundi, but you send your message in the chat from Kano, Nigeria, only to the panelists. So it's only Francois and myself who can see where you're joining us from. The other scholars cannot see. If you could type, welcome to you, Ponyak Victor Bako from Plateau State in Nigeria. If you could type in your city and your country and all the messages you're going to send, ensuring that it is addressed to all panelists and attendees. Please, I hope you're seeing my screen and you're seeing the red arrow that's indicating on the chat all panelists and attendees. And the greetings to you, Matthew Joka. I saw you got it. I see you got it right from South Sudan. You send your message to all panelists and attendees. And special welcome to Muhammed Imran Qureshi, and happy Feast of the Tabaski to you, Muhammad. All right, so welcome to you, Nuhu Sani Wara from Kebbi State in Nigeria. So we are going to move ahead today. If you have a question, you know the Q&A button is there, so you type in your question in the Q&A, and we'll be delighted to read it out so that colleagues can attempt to answer. Want to start by giving you some updates on the IDS engine. Congratulations to the 1,300 scholars who have joined the IDS engine, and more congratulations to the 500 plus ideas and practices that have been shared in the IDS engine. I'm so excited about it. And if you are in the room now and you have shared your idea in the IDS engine, then you'll have the opportunity to speak about what you shared with us in this session and get useful feedback from Francois Gaz and your peers. So I'll just in a moment invite you to raise your hand, and I'll be delighted to ask you to unmute yourself and to share your idea with us. So if you want to learn how to search these ideas in the IDS engine for the most relevant ones for you, then there are two tutorials that you need to watch. And I'm just going to post the links on the chat so that you'll be able to watch these tutorials. You just click on the link to watch the tutorials that Ian made available for us. Oh, unfortunately, wrong manipulation. All right. So I'm just sharing the links on the chat for the benefit. And while I'm doing that, I would like to invite Francois Gaz to begin to just briefly tell us what this exercise is all about, exercise 1 of the peer hub, and why it is necessary for you to share your ideas in the IDS engine based on a certain number of challenges that were identified. Good evening, Francois, and over to you.
Good evening, Charlotte, and good evening to people who are in Nepal and late afternoon in many other, but wherever you are, I'm happy to be with you tonight. So you all have been facing challenges. You know those challenges because they have been shared, and you are facing with what we summarize in 7 challenges that you see in front of your eyes, which are linked to outbreak of vaccine preventable disease, ensuring a safe vaccination campaign, if they were planned, health worker safety, demand of caregivers for vaccination, catch-up strategies, disruption of vaccine because logistics has been a problem, and human resources who have the capacity to deliver the vaccine in spite of their other activities in COVID. So you are facing one or several of those challenges. You need to respond with an idea, which means a solution. And what we are here is to hear the solution to those challenges? How do you respond effectively? How you restore demand, etc.? So please, we expect the presenter, who will be identified by Charlotte, to be clear on what the problem, specific problems they've faced, and explain clearly what idea they have they have implemented or they are going to implement, and how in practice they're going to implement their idea to respond to the problem, the challenge they face. And we hope that they can also mention how they're going to monitor that the idea they implement in practice will make a difference. How they're going to monitor that in practice to either adjust, improve the idea in their implementation, or add new ideas or move to another one. So the floor is to you, and Charlotte, over to you. Thank you.
Thank you very much, Francois. And I'm already seeing a raised hand, and it is the eminent Muhammed Imran Qureshi. Mohammed, I'm so glad to have you with us this evening, and I'll invite you to unmute yourself, and you have the floor.
Thank you.
I'm just pasting the questions on the chat, and when it's possible, you go ahead, Mohammed.
Yeah, thank you very much for giving me the floor. And yes, once this COVID pandemic challenge is there, it is already disturbing many of the scenarios, and the immunization coverage is no more different. So the immunization coverage is not very well during this COVID pandemic. I believe there are three major reasons. The first reason is basically the disruption of the service delivery. The second reason is the disturbance in the supply chain of vaccine demand. And third is obviously the community attitude change, where they were like concerned about the safety of their kids during this COVID pandemic. So resultantly, the coverage has decreased. And once the coverage has decreased, there are likely chances for finding outbreaks and cases of vaccine preventable diseases. So I'm just talking about in the context of Pakistan, which is the fifth largest populous country of the world. So in Pakistan, the situation was no more different. Because of the decrease in the immunization coverage, there were like outbreaks, and those outbreaks can be picked up only by very good data compilation and analysis. So the district level, and even I'll go below district level, which is the Union Council, the lowest administrative unit in Pakistan. So we picked some of the outbreaks related to measles. Specifically coming to three districts of Pakistan, like Rawalpindi, Lahore, and Attak, we picked a UC level measles outbreak, and then the challenge was huge to respond to these outbreaks. So the good aspect was that outbreak response immunization, which we usually call ORI, was planned very well. The micro planning was done at the Union Council level, and we explored all the possible ways and means how to just tackle the situation of COVID while delivering this outbreak response immunization. So we prepared a very good micro plan at the Union Council level, engaged multiple resources, identified many precautionary measures which we had to take during this COVID pandemic to deliver the vaccine to the kids. So the good aspect was the pre-campaign phase of ORI was very good. Considering the COVID pandemic, where we focused all these COVID precautionary measures in training of the healthcare workers who were engaged in this outbreak response immunization, then engaged multiple other resources and ensured that at least three major precautionary measures must be taken, which was social distancing, hand hygiene, and the face mask. So these things were ensured during this outbreak response immunization, and during the ORI period, one thing was very good, that the monitoring aspect, the district and the provincial level, they did wonderful monitoring of this activity. Although there was some reluctancy, we would not say that there was no challenge from the community side. But one thing was good, that the all the defaulters who were not appearing to this outbreak response immunization sessions, they were recorded by the social mobilizers who were going door to door. And we were really amazed to see the end results of this outbreak response immunization, which was so satisfactory that it was already more than 95% coverage of these outbreak response immunizations. And the districts were able to contain those outbreaks and contain the deaths, which could happen otherwise. So this was a very good success story, which would like in my mind to share with you, considering the previous questions which you showed to us. Thank you very much.
Thank you very much, Muhammed Imran, for sharing this very interesting story with us. And I'd just like you to stand by for a few questions. And I'd just like to invite those who have listened, if you've been listening to the story, like I tapped in the chat, that if you have any questions for Muhammed, you can type them here in the chat, and I'll be delighted to read them out to him. So, Muhammed, there is a first question from Satabdi Mitra that asks, hi, Muhammed, what is the status of serosurveillance in your country?
Thank you very much for this very important question. You know, serosurveillance is going on. I mean, we are just getting samples and the samples are being tested. So the serosurveillance is never stopped. And we are having a regional reference lab, which is NIH in Islamabad. So the lab is already testing all the cases for the vaccine preventable diseases. And yes, there was positivity was coming out. So we were being able to pick all those measles, diphtheria, pertussis, NNT, and then AFP cases during this serosurveillance. And apart from serosurveillance, I also want to add that now there is a trend in the country that the country probably move now to serosurveys as well. So that thing will add up in identifying the low immunization coverage areas. And definitely we will like have three-pronged strategies. Firstly, for each and every reported case, we go for 30 household case response. And then for union council level, which is the lowest administrative unit, for the outbreak response immunization. And then another thing, which is the extended mop-up. So if any suspected case whose sample was sent to the lab and the lab just sent us the result that the case was positive, let's say, for example, for measles, then at least 160 houses surrounding the index case, a greater mop-up is always being conducted. So all these three strategies, case response, mop-up for the positive cases, and outbreak response immunization for the outbreaks, it has resulted in very good containment of these vaccine preventable diseases and outbreaks. In all these strategies, we just identify all the due and defaulter children, cover all the due and defaulter children for all the antigens. Then the second aspect is giving the booster dose. Third aspect is the active search to identify more and more vaccine preventable diseases cases. And last aspect is just to give pick up epi-linked cases. And if the epi-linked cases are picked up, then probably we need to just investigate, collect sample if required. And then we also give vitamin A and erythromycin for diphtheria. So this is the simple strategy we are following in Pakistan. Thank you.
Okay, thank you, Mohammed. I see another question here from Bala that says, Dr. Mohammed, nice presentation of the scenario. Instead of waiting for outbreaks and going for ORI, why can't you directly organize catch-up campaigns in low coverage areas?
Excellent question. And you know, for the very just for a few years, the country has started a very good initiative, which is called enhanced outreach activity. So this enhanced outreach activity is just enabling the country to improve the coverage in low coverage areas. All those low coverage areas are first identified, then extra resources are mobilized, social mobilizers are engaged, vaccine were ensured, and then micro planning is done. With good monitoring and engagement of social mobilizers, extra vaccination teams are arranged. and then they are like moving in a very with a very good red micro planning to the community to conduct these enhanced outreach vaccination sessions, and that has increased the overall coverage. Although this COVID pandemic has caused multiple problems, you know, the another problem which was very serious in our context was we were not getting the required number of vaccine doses. So the supply chain was disturbed very much. Now the supply chain is improving a bit and number of doses are being provided. So the good aspect is once you have a vaccine and your supply chain services, vaccination points are already functional, then community is also cooperating and understanding the situation. By ensuring and building the community trust, you are requesting people to come for the vaccination points and get required vaccination. So the another initiative which is started in the country is development of all the due and defaulters list at the union council level, at the vaccinator level. Those lists are compiled at the district level and submitted at the provincial or the governor level, where you could see the gravity of the problem and you could follow all those defaulter children once they are enlisted. Thank you.
Thank you very much, Muhammad. And just the last question from Ponyak Victor Bako. And as I said earlier, when you want to type in the chat, make sure you're typing to all panelists and attendees. So what's the way out or solution for high dropout rate of Penta 1 and Penta 3 vaccine? I just think this is what you have been talking about all this while. So
yeah, I want to add a bit. Like although the supply chain of required vaccine doses was disturbed, but the most affected antigen was pentavalent. So now penta supply is getting restored and districts are getting the required number of vaccine doses. So the challenge was, although they would cover the current month target, but what about the huge backlog or the defaulters which are already there? So the initiative taken in this context is really good. These enhanced outreach activity, EOA, and then combined with the compilation of all the due and defaulter list children at the union council level and their compilation at the district level. These both things together with the enhanced monitoring of all the vaccination sessions has resulted in improving immunization coverage. And we are pretty sure that inshallah soon, in a couple of months, we will cover our defaulter children.
Thank you, Mohammed, and thank you to all those that are putting very nice comments in the chat. That's a very good presentation. And before I invite Francois Gaz for his observations and questions, there is a last question in the Q&A from Amsalu Shifarol that says, was the catch-up campaign made for specific antigens or for all? For example, how did you administer polio vaccines as is a multi-dose and provided orally, which might have the likelihood of contamination during
yeah, thank you very much.
Of OPV?
Basically two approaches. First is for routine immunization. So for routine immunization, I already explained, we the major reliance on enlisting the due and defaulter children, then conducting the enhanced outreach activity by following the red approach and mobilizing the social mobilizers and then monitoring the whole process. So that is for routine immunization, and that is for all the antigens. It is not for one antigen or two antigen. It is for all the antigen for all the due and defaulter children. The second most important aspect, as you know already, country is struggling for polio eradication along with Afghanistan, only two countries in the world. So another challenge in the country is to resume the campaigns as far as the polio vaccination is concerned, polio SIAs. So for this context, the good aspect and good news is we have successfully conducted polio vaccination campaign in selected districts and areas of the country. Although the coverage is not too ideal, frankly speaking, but yes, it is satisfactory that after the campaign, all the monitoring surveys, which we usually called lot quality assurance sampling, many of them are passing, which shows that the coverage is already more than 90 to 95%. Thank you.
Thank you very much, Mohammed. And Francois, over to you for your observations. And if there are more questions that you would like to ask Muhammed Imran Qureshi after his beautiful presentation.
Thank you, Charlotte, and thank you, Mohammed, for sharing your experience in Pakistan in undertaking a catch-up campaign, a measles campaign. You answered at the end. When we see results of campaign, very often we see huge, very comprehensive result. But unless you have this lot quality assessment to check the real coverage achieved, I'm aware that when you did a campaign, is that the same measles campaign you're talking about or a new one? Was very good in Sindh province. I visited not a long time ago. I wanted to know, in those campaigns, there are localized campaign, at what level you are working, and when you talk about the campaign, at which level are you, and what level of the campaign you were describing? That's my first question.
Thank you very much. My name is Dr. Muhammad Imran Qureshi, and I'm working as technical officer in EPI WHO Punjab. I'm dealing with Punjab at the provincial level, which is the largest province of the country, more than 52% of the country population. And this campaign's execution of the campaign was at the district level. So the districts were selected based on the risk. So risk-based assessment of the districts was conducted. And although this was not NID, which we usually call National Immunization Days, which is conducted simultaneously throughout the country, and it was more like a SNID, which was Sub-National Immunization Activity. And the targeted districts were selected for this polio campaign, and those targeted districts were selected, and then the campaign was conducted in those areas. There were like a lot of challenge to conduct these campaigns during this COVID pandemic, where the healthcare workers are the vaccination teams. They have their own concerns to go to the field and to deliver the vaccine drops to the children. But the other aspect was the community acceptance. So during this polio campaigns, special trainings were conducted for all those healthcare workers, how they will like ensure proper precautionary measures to be followed during this polio campaigns. For example, they were specifically instructed for polio vaccination drops. So if the polio dropper touches one child, the team was instructed to replace and start another new vial with a new dropper, just to ensure that the cross contamination is not happening and to avoid these COVID pandemic transmission of infection. Thank you.
One question I have, my next question, you're talking about the identification of the defaulters. And as you mentioned, it's a huge country. Punjab is huge. A district in Punjab is huge, is the size of some African countries sometimes. So what was the human resources you needed to really check house by house on registers all the defaulters, the children that needed vaccine? What was your secret? That is a huge task. And you need competent people who can assess the immunization status and say, this one is missing Penta 2 and Penta 3, this one measles, this one. How did you do that? What was the critical element that you need to succeed in doing that?
Okay, considering this multi-antigen sort of activity, which we are calling enhanced outreach activity, we are already registering all the defaulter children. The problem was, yes, was huge, how to just enlist all those defaulter children. And for that reasons, the micro planning was very critical. And now each and every vaccinator was provided with one social mobilizer, or either that is the frontline community health worker in the form of lady health worker, LHW we usually call, or the dengue staff or other field staff. But if the union council, there are certain communities which are not covered with frontline community healthcare workers, then social mobilizers are chosen from the community who are from their community, and they were trained enough to enlist all those defaulters by visiting house to house. So this activity was really fruitful to conduct the house-to-house sport, not only to mobilize the community towards the vaccination points, but also enlisting all those who were found defaulters and all those who were unable due to any good reason to go to the vaccination point, they were enlisted so that they could be covered later on. Thank you.
Thank you very much. Punjab is doing a great job. I think even in polio eradication in Pakistan, you have eliminated tetanus. So obviously you have a system that works and on which you have built to address your recent challenge of protecting PVD and with your extension. Now, my last question is, would you think that what you have done would work in other provinces that have a lesser infrastructure, like Sindh province or Balochistan? Do you think the other province can use your approach or will face challenges?
Yeah, you're right. I mean, lessons learned within country can be applied to other areas, but I'm just describing one initiative and activity supported by WHO, executed by federal EPI and the provincial EPIs, is equally conducted in all the provinces, whether it is Balochistan, whether it is Sindh, whether it is Khyber Pakhtunkhwa, and even Punjab, and also the federating areas, Gilgit-Baltistan, Islamabad, and then AJK, which is Azad Jammu and Kashmir. So this initiative of EOA is being conducted everywhere across the country, and I'm sure it is bringing results. Yes, it will take some time, but we are optimistic that we will get results. Thank you.
Thank you very much.
So really, thank you very much, Francois and Mohammed. And with the number of comments that I'm seeing in the chats and even the questions in the Q&A, I think this is a presentation that has gotten a lot of attention. And I may be able to read a few of those questions and the comments. There is this one from Ephraim O. Ezekiel that says, Dr. Nice presentation. I heard you say the mobilizers were going house to house. How did you address this issue along the coastal region of your country? I don't know if it's somebody that knows your country. So Mohammed, if you could just unmute yourself again, and is there an answer to Ephraim Ezekiel's?
Pardon, can you just repeat the question?
He say, Dr. Nice presentation. I heard you say the mobilizers were going from house to house. How did you address this issue along the coastal region of your country? I don't know if it's a matter of accessibility or what.
Yeah, you know, accessibility is a huge challenge, but the country doesn't have always these accessibility challenges. Generally, the challenge is not too high. Majority of the country areas, like for example, if I could have to give you in percentages, 60% of the country is covered with frontline community healthcare workers. For example, lady health worker, LHW, or other preventive outreach team people like CDC supervisor, like sanitary patrol, like dengue staff. So these people are already available. Only the challenge is the left 40% of the area where we don't have such luxuries of community healthcare workers. Then in those areas, the social mobilizers who are not government employees, they are volunteers, they are taken on board, they are given training, proper training, and then they are engaged. But yes, one thing to confess is the extremely hard trains, for example, these coastal areas or these hilly areas, mountain areas, yes, they are huge challenge. But yes, the people who are already available, either they are the government employees, the community frontline healthcare workers, or they are the paid volunteers. They do definitely play their role, and we always get good coverage in those areas as well.
All right, thank you. And there is a Mercy A. Onu Peters that asks that Mohammed, is there new, are there any new, something you discovered while carrying out these activities that are not in a micro plan in your area? If yes, what do you plan to do for this period? It means that was there something that surprised you or that you found out, you know, that had not been planned previously in the micro plans? And then what do you intend to do about that?
Yes, during micro planning, two aspects are always taken in mind. First is the desk review of the micro plans, and second is the field validation. But yes, it's a huge country. At times, you come across to certain situations where the areas were not included in the micro plans. And yes, during especially monitoring of the immunization sessions, we come across certain areas which are not already included in the micro plans. Then in that situation, those areas are always included, and active search is already conducted on those areas, so that if any defaulter is there, it can be like taken in on list and then covered subsequently. Thank you.
All right, thank you very much, Mohammed, and thank you for taking out the time to really answer these questions and explain about the situation in your country. And I'm sure that many scholars in the room, they have learned a lot. And when I look at the comments, I see that many people that are thanking you, that are saying nice explanations and presentation. And so I think it's been very beneficial. Now I'm turning to the Q&A to address some questions that were not directly sent to, that were not directly directed to Mohammed. That has to do with the IGS engine and the exercise as a whole. So we are already, it's already 6:30. The time goes by so fast. And I think for today, we can just digest this one idea that an experience shared by Muhammed Imran Qureshi from Pakistan that has been very rich. And so I'm just going to try to address these questions. And then afterwards, I'll invite Francois Gaz to just give a summary of maybe some lessons learned, what we need to really keep in mind and retain from the experience and the ideas shared by Muhammed Imran Qureshi this evening. So the first question, there is a question from Abbas Kwate that say, hello, can you make this quite clear? The exercise 1 and the idea, I am through with the exercise 1 at the hub, but not clear with the idea and where to submit it. Thanks. So Abbas Kwate, part of exercise 1 this week, let me just put on the screen the schedule for exercise 1. Exercise 1 is a whole series of activities that lead up to you preparing and submitting a project. This first week, what we're supposed to do was, they say, the ideas engine week 1. Join the ideas engine, explore and share experiences and ideas. And on Monday, Reda sent out mails to everyone in the peer hub with the links to join the ideas engine. It's a platform. I don't know if I could just share my screen a little bit so that you could have a view of what we are talking about. But I will encourage you to join the technical support session on Monday at 11 a.m. Geneva time with Alain Blaise Tatinku. Those sessions are the sessions in which you get technical support. Is going to be a very useful and helpful session for you. So I'll encourage you to join that session if you want to get more clarity, and probably there will be somebody that can guide you around and show you exactly where the ideas engine is. So I'm just trying to see if I can open the right page. All right. And then, so here is what the ideas engine looks like. This is when, once you have already logged on, this is what the ideas engine looks like. Let me just go to the home page. On the home page, first and foremost, you're going to get a welcome message from Reda. And then you will see the 7 challenges that were identified that Francois Gaz explained earlier on. Those 7 challenges are there. And if you identify with any of these challenges, you click and you can add your idea. You can add your idea. So if you can begin to see, you already see 80 idea creators that have to do with health worker safety, 61 ideas that have to do with catch up, you know. So I'll just invite you, maybe after the session, you could go on the Telegram platform and you will see the links are there, the tutorials are there on how to join the ideas engine. Ian Steed from the Scholar team prepared some very clear tutorials on how you can join the ideas engine. So the ideas engine, posting your idea in the ideas engine is just one aspect of exercise 1. And as I shared earlier on the calendar, next week we are going to go through reviewing the ideas and trying to see what you can gain from them. And then there is this question from Abraham Amadu that says, are scholars expected to post ideas in all 7 main challenges identified on the ideas engine? The answer is no. You are not expected to post for all 7, but if you have ideas, if you have the time, and if you have the ideas to post for more than 1 challenge, then good and fine, because all those ideas could be useful and helpful for one of your peers. So if you're facing more than 1 challenge and you have tried to address it with more than 1 ideas, you could post that, but you are not expected to post for all ideas in all the 7 main challenges. I hope your question is answered, Abraham Amadu. All right, so I think that's all for the questions on the Q&A. Now I'm just going to, and then there is a comment from Philippe Kwal that says, what are some strategies to use to convince caregivers? Really today, the challenge was not the idea. Philippe, I just want to invite you to come back for our session next Tuesday at 6 p.m. Geneva time. And we will be delighted to get to talk about that. So right now I'm going to invite Francois Gaz to just give parting advice, what you need to retain from the idea and the experience that was shared today. And then we're going to conclude for this week. Over to you, Francois.
Thank you, Charlotte. And thank you, Mohammed, for taking the time to explain your problem, the idea you put in place to address vaccine prevent your enhanced outreach activities, which I believe is a good response, not only to the risk of outbreak of measles, but also to do a better routine that will prevent outbreak in the future. And this is very nice. And you have explained the various steps, and you have the different place, and particularly the micro planning. You have put an emphasis on micro planning, on the registration of the defaulter, which are a very good concrete idea. And I would like to stress for people in the future session to really come in the activity to solve the challenge, not to have a generic approach like let's restore demand. What we're interested is to know what area of challenge you're addressing and how in practice you're addressing this problem, and who does what, when, and how. And maybe one element which is important to make your idea very understandable, and knowing if the context meets somebody, some country, some else manager in another country, is what's the context when you implement the idea, what are the critical success factors that make your idea work and happen and gives the expected result. You mentioned the extensive rate of ladies workers. Some countries don't have it, so they may not, they say, oh, this is too much workload, but some countries have extension workers or similar, like Ethiopia, where your idea would, I'm sure, work beautifully. So it's important to enter in the data and maybe to share the difficulties, and not only the success, but what was the difficulty in when you describe your, and how you've been able to overcome them, and how especially you measure that it's working, and you can confirm that you have done, you have a success story, because data are not always reliable, and we all know we have denominator issues, we have numerator issues, as you know. So we need to know how did you monitor and get confidence that your idea is working and getting the results you need. And I would recommend that when you implement your idea or your ideas for several challenge, make sure that all the questions which are asked in the idea engine are really listed in detail, that everybody will feel confident to understand what you have done. So thank you very much again, Mohammed, and thank you for all who are here, and have a very nice celebration day if you are Muslim, where you have the Tabaski, and please enjoy the day with the family. Thank you for being there. Over to you.
Thank you very much, Francois, guys. And Mohammed, thank you so much for being there to share your experience with us this evening. And I do hope you'll be contributing these wonderful ideas in the ideas engine if you have not yet done so. And I know that in the past, you have enriched the ideas engine during the pilot phase with a very pertinent idea. And I hope that this time we have a larger group of people in the peer hub, a larger group of scholars in the peer hub. And I do hope they'll get to benefit from your experience as far as responding to immunization challenges within the context of COVID-19 is concerned. And that said, I do hope to meet all of you next Tuesday at 6 p.m. Geneva time. And do remember that on Monday, we'll be having our Global Assembly, the COVID-19 Peer Hub Global Assembly next Monday. So do ensure that you are there. And if you have any questions, the country groups are there. You could ask your questions in the Telegram country groups or in the COVID-19 Peer Hub country group, and we'll be there. There is also the share form, share with the scholar team form. You can fill it out. You have support on every side because in the scholar program, the scholar is at the center of every intervention. Look forward to seeing you next week on Tuesday. And until then, happy Feast of the Tabaski to all our Muslim scholars and peers, and have a nice weekend to the rest of you all. Thank you and bye for now.
Thank you.
Thank you very much and stay safe.
Thank you. Bye.
Bye.